Thank you. Thank you, Tony, for the invitation, and thank you, Dr. Sharma, also for letting me speak on this topic that it's been worked for many years now. And thank you for the Cornea Society for letting me participate. Yes, like Dr. Aldave said, I'm going to talk about the use of rose bengal for patients with progressive keratitis. For my financial disclosures, I don't have a financial interest. I do own part of the patent of the light source that we use. And what I'm presenting is experimental and is not yet FDA approved. We're trying really hard, but not yet. This has been a total teamwork. I work, very lucky to work under the leadership of Dr. John Marie Perel and many others, and lucky to have my boss and mentors that have been supporting me this project for now years. So living in South Florida is like living on a petri dish. So we see a lot of keratitis, and many patients come from far away, from the Caribbean islands, from out of state, etc., with progressive keratitis. And these are our culture positivity rates, and the organisms are our enemies that I call. Gram negatives by far the most common because of the tropical weather. We do see significant amount of fungi in keratitis, and you can see here the rest of atypicals. So if you go back and look at this publication, it's very interesting. 1973 from Dr. Dan Jones, and this publication, you read it, and we're in 2021, and we are still doing many things the same. Many antibiotics that he mentions are the ones that we use. In my career, haven't seen many new antibiotics developed. We're still using the same commercially available antifungal, natamycin. We do use some compounding antifungals, but there's not a lot of tools for many aggressive organisms that we see. So this publication, Dr. Jones, the strategies that he mentions are strategies that we're still using, like trusting a gram stain or trusting a calcofluor white to decide our treatment. So I think if you have a practice with a significant amount of infectious keratitis, we can summarize it by saying that for bacterial and for viral disease, we have a pretty good way to treat them. If you have access to fortified antibiotics and the patient is compliant, if you catch it early, the patients will probably going to do just fine. And but for atypical bacteria, not so good. And for fungal and parasitic, we still have a lot of room to work. And these are the cases that we see. This is a typical Friday afternoon at 4:30 p.m. when the resident comes and tells you that it has a red eye that needs help. And, so the infection is going to the sclera, the cornea is half the thickness that it should be. And you're excited early in your career to do therapeutic keratoplasty, but then you have to follow this patient. They develop glaucoma, develop graft rejections. And so, this is what the project's all about. Try to eliminate or decrease the number of patients that we have to take to the operating room for a therapeutic transplant. So when I joined the faculty after my fellowship, this was very popular. The cross-linking was getting approved in the US, and it was very popular in the rest of the world for keratoconus, and it was demonstrated with significant evidence that there was an increased resistance to enzymatic degradation that will make the collagen fibers better. So we started to ask the question, can we use this cross-linking with riboflavin and UV light to help the problem that we have in South Florida? And Dr. John Marie Perel and his team of engineers built for us a custom-made light source following the Dresden protocol. And this was one of the first patients that we treated with a fulminant pseudomonas, a young female. And we used this device that was built by Dr. Perel. And you can see here that the patient normally will develop this significant neovascularization. They'll start healing. The disease is stopping the melting. And we see this frequently in patients that we treat with either cross-linking or now PDT, photodynamic therapy. And this is what we want. We want to do a transplant when the eye looks like this. We don't want to do a transplant when the eye is very inflamed and everyone here is in agreement that the prognosis will be so much better if you do the transplant in a quiet eye. And this has been the case with this patient that I still follow many years later. She was one of the first patients, like I said, and she refracts with a good vision and the graphs is still good. Then there's a lot of conflicting data on the efficacy of using cross-linking. I'm talking about riboflavin with UV light. A recent publication from the group of the Proctor Foundation under the leadership of Dr. Jennifer Rose show that the results are not incredibly good for the use of riboflavin, maybe decreasing the rate of positivity on the cultures and maybe decreasing some complications. This study, it helped to bring another study that that's happening now in Arvin, and hopefully soon in the next month we'll start recruiting here in our center, where we're going to use cross-linking with riboflavin to see if we can help some of these bacterial infections. The group from Dr. Hafezi has done a good job trying to move this technology forward to see if we can help patients with infectious keratitis. And they published that using higher fluence may help improve the outcomes. We used to use UV light, and we published our results and with some benefit in some of the patients. But when we started doing our in vitro studies, we started looking at different photosensitizing agents, and we decided on rose bengal for obvious reasons. One is inexpensive. We have a long track record of safety in ophthalmology. So we decided to start doing that. It happens that rose bengal is a very strong photosensitizing agent. It releases a lot of single oxygen. And we were not doing anything new. There were many groups publishing on how rose bengal can increase collagen, the stiffness of the collagen fibers, and it's been shown to be safe in the use of in an animal model, in a rabbit model, by the group in Spain and by the group of Dr. Koshibar in Boston. So we felt comfortable bringing this technology. We built the light source, they custom made. And we started doing our in vitro data. And this is one of our first publications that injected a lot of energy to our group to start moving forward, where we compare with riboflavin and UV light. And for our three most common fungal organisms, we had 100% kill in the area of irradiations: Candida, Aspergillus, and Fusarium. And the same has happened with many other bugs that we tested: multi-drug resistant methicillin resistant Staph aureus and multi-drug resistant Pseudomonas. We started doing research on how safe this was for the ocular surface. Are we going to damage the limbal stem cells? And with this scratch model on a rabbit, treating the right eye and using the left eye as control, we didn't see any issues with healing of the epithelium. And then we asked the question, are we doing any damage to the endothelium? And I personally debated with Dr. Perella, saying, I really don't, not that I don't care, but I'd rather just stop the infection and do the transplant when the eye is quiet. If the endothelium suffers and we stop the infection, to me it's still a win, but we have to do things the right way, and we have to follow FDA guidelines, and we did it, and there was no, in a healthy rabbit model, there was no damage. So we recently published in the Journal of Cornea a in vitro study showing, again, good safety in using our protocol. We analyzed the tissues inside the eye, the lens, the retina, the iris, and there was no problem. This was our first publication. This patient came desperate with a rapid progressive Fusarium infection that was not responding to the standard medical care. And it happens that we used her sample for one of our in vitro studies, and we show 100% killing. And she was very smart and read some of the publications and asked us to do it. We got the proper consent, and we did it. And she ended up healing that cornea and later on receiving an optical transplant. So we put together all of our results that we had at that time. This is a publication for almost 2 years ago, a year and a half ago, and where we feel that we stop or prevented many patients from going to the operating room. Now it's not been very scientific way to do this, because we basically started doing it in patients who had very severe disease because of the regulatory issues around this. But recently we partnered with a company that makes medical grade rose bengal, and we are doing a formal collaboration with a new grant from the University of Miami in collaboration with them. And we're starting to test this rose bengal that's coming from them. The company is called Provectus, and it gets activated with the same wavelength of the ones that we use. We've done all the chemical analysis and to show that is pure and enough quality to be used. Of course, it's been used in that company for other oncological indications. It's been used in the form of IV, so we feel comfortable using in the form of topical treatment. So we've repeated a lot of the experiments that we've already done with the Sigma rose bengal, and we've been pretty happy with the results. We did all the in vitro studies that you've seen before, and they've been already published. In this is a candida, this is fusarium, comparing Provectus with the Sigma rose bengal, and Aspergillus is the one that we've been surprised that we've not been getting the results we wanted recently. So we are studying the different types of Aspergillus, and also we repeated our animal data, our animal studies with this new medical grade rose bengal, and we haven't seen any issues in epithelial healing using this rose bengal. One of our engineer students, MD PhD students, got interested in this project, and he amazingly developed under the mentorship of Dr. Perel, a device that can detect and measure how much single oxygens is being released when you're doing the treatment, and this is going to help us titrate what's a better dose for the treatment, what's the duration that the treatment should have. There's so many questions that we still need to answer. So credit here is to Dr. Jeffrey Peterson, who soon will be applying to a residency position. So all of you program directors, he really has done a great job. So this is a recent case, and you know, I've always tried to remain as unbiased as possible with this project, but this case to me really proved that we've saved some patients from going into surgery. This is a patient that was from Argentina that got stuck here in Miami during the pandemic. He had no flights. He was extending his use of contact lenses. So in June last year, he showed up with this fulminant serratia. The attending at that time felt that the infection may be also involving the sclera. It was not blanching with phenylephrine. The patient was in severe pain. So they were already scheduling surgery, and one of the residents proposed to the patient the option of doing this procedure, and we did it. And the patient eventually healed and left back to Argentina. His epithelium healed, pain went away, and he came recently back for follow-up. And I was just so amazed how his cornea looked. Look and see, you know, how the cornea looked before treatment and how the cornea looked just a couple of weeks ago. I did cataract surgery last Tuesday on him, and his vision is actually pretty decent. So we're not thinking on doing any keratoplasty on this patient. So so far, you know, the patients that we've seen the best results have been patients with very severe gram-negative infections, patients surprisingly with acanthamoeba. We've been unlucky to or not very good results in vitro with acanthamoeba, but clinically we've seen many patients that turn around, and we're not very happy actually with the results of the fungal keratitis, and it's interesting because that's the main reason we started this project. But one of the reasons may be that we are treating the patients when they present very severe with very deep infections. The fungal patients that we've treated and in the early stages of the disease, patients with infections in the first and anterior part of the cornea, have done actually pretty well. But most of our failures are being very severe fusarium or Aspergillus infections. So in summary, I think we all can agree that we need better treatments for infectious keratitis. We hope that this rose bengal photodynamic therapy may be a future option for the treatment of infectious keratitis. There's many questions that we still need to answer. You know, how much is this photosensitizing penetrating in the cornea? We know that it penetrates in a healthy cornea, and a healthy rabbit cornea, to about 120 to 150 microns. What's the fluence that we need to use, the timing of the treatment, the number of the treatments, and are there other photosensitizing agents that could be more potent? And so those are the questions, and I thank you very much for letting me present our research.
Thank you very much for that insightful presentation.